This presentation is titled Dimensions of Ethics, Perspectives on Spirituality. Our objectives today, we will look at professional boundaries in general and boundaries pertaining to religion and spirituality in particular. Understand how power and vulnerability work within professional boundaries. An exploration of the concepts of transference and countertransference. Explore the differences between religion and spirituality and learn ways in which to talk about religion and spirituality to patients, including active listening skills. And the reason why we're starting out by looking at boundaries is because understanding the ethical implications of boundaries is sort of the foundation in which to build upon other things that we'll be learning here in this presentation. So understanding boundaries. It is the professional caregiver's responsibility to set and maintain clear, appropriate professional boundaries with patients. Professional boundaries may be conceptualized as fences, which function to protect an individual, both the caregiver and the care seeker. The art of professional practice is to understand how to engage with patients with clear and appropriate boundaries. So we're going to look at boundaries as fences. So to give a visual image of what I mean by boundaries. So here's an example of a boundary that's too rigid. When providing care for people, you can either be too rigid or you can share too much. So the important thing to recognize is that middle area that we all need to maintain. Here's another example of having way too rigid of boundaries. And this is an example of not having boundaries enough and sharing too much information and crossing those boundaries all the time. That's not a good thing. This is an image of a boundary that you have good boundaries most of the time, but there's a trigger here and there that cause you to violate. And that trigger could be, let's say you and a patient have the same background. Let's say you went to the same school, you're the same religion, something that's maybe a commonality that triggers you to sort of think it's okay to cross those boundaries because of that commonality. So it's something to be very mindful of. This is an example of, the patient has good boundaries, you have good boundaries, everything's great, good care is provided, there's no challenge. But sometimes you'll have a situation where you have good boundaries and the patient or family's always trying to cross that, and you have to be extra diligent. So understanding boundaries, professional boundaries are the spaces between the caregiver's power and the patient's vulnerability. These boundaries create a zone of helpfulness, allowing for a safe connection between caregiver and the patient. One way to look at these boundaries is as a continuum or range of behaviors. At one end is the zone of over-involvement, and at the other of under-involvement. The zone of helpfulness is in the middle. Patient harm can occur at either end of this continuum. So here's an image of this zone of helpfulness. That zone of helpfulness is that middle area in between disengagement and over-involvement, something that we need to be very mindful of when providing care for others. So what does disengagement or little involvement look like? The caregiver is cold and disengaged. The caregiver is seen as distant and detached, and it's often seen as rigid boundaries. It could also be that the caregiver is maybe on their cell phone too much, always checking their email, checking Facebook, doing things that they shouldn't be doing when they should be focusing on the patient. And over-involvement. The caregiver shares too much personal information, often too quickly. The caregiver becomes involved with patients' personal problems. At one time, I had a chaplain intern who interned with me, and I was doing a new assessment for a patient, so I asked her to go visit a patient that was already on my caseload. And then later that week, I visited with that patient, and the patient proceeded to tell me all about the intern, all about the intern's daughter, and just a lot of personal information that the chaplain intern shared in maybe a 20, 30-minute visit. And that was a lot more information than that patient should know about that chaplain intern. It's okay to share some personal information, but be very mindful of how you do it. If you've been seeing a patient for a year, yeah, they're going to know some things about you, but they shouldn't know everything about you in 20 minutes. So healthy boundaries shares personal information in an appropriate way, does not over or undershare, values one's own opinions and the opinions of others, doesn't compromise values, maintains a code of ethics. I've had patients where I visited with them for an hour, hour and a half, and at the end of the visit, they've said, more people need to believe like us, even though I don't believe anything like the patient does. I maintain my own integrity. I did my job as a chaplain, affirming their feelings and using active listening, but I didn't engage in a debate or discussion about politics that would take away from this caregiving opportunity that I had to provide good quality pastoral care. And you can do that and maintain your own values and integrity without having to constantly defend yourself, especially in these political times that we're in now. So what type of boundaries are there? They're physical boundaries, intellectual boundaries, emotional, sexual, material, and time boundaries. And let's look at these individually. So physical boundaries. Physical boundaries refer to personal space and physical touch. Healthy physical boundaries include an awareness of what's appropriate and what's not in various settings and types of relationships, hugging, shaking hands, etc. Physical boundaries may be violated if someone touches you when you don't want them to, or when someone's personal space is violated, going through someone's stuff. So it may not be appropriate to hug a patient when you first met them, but it may be appropriate at a funeral of a family member. If you're there at the funeral and they come up to you, and that may be appropriate. If you're an STNA and you're having to get a patient ready for their bath or their shower and you have to get their clothes, you might want to say, hey, Mr. So-and-so, I'm going to look for clothes for you to wear, and then go do it without just doing it without letting them know what you're doing. So what are some intellectual boundaries? Intellectual boundaries refer to thoughts and ideas. Healthy intellectual boundaries include respect for the ideas of others and an awareness of appropriate discussion. Talk about the weather or talk about politics, but always be respectful. Intellectual boundaries are violated when someone dismisses or belittles another person's thoughts and ideas. Like I mentioned earlier, I've had plenty of opportunities to meet with patients and families who have views very different from my own, but I'm going to affirm the values that they have without diminishing them, even though we may not have the same values. Emotional boundaries refer to a person's feelings. Healthy emotional boundaries include limitations on when to share and when not to share personal information. For example, gradually sharing personal information during the development of a relationship, as opposed to revealing everything to everyone. Emotional boundaries are violated when someone criticizes, belittles, or invalidates another person's feelings. Then we have sexual boundaries, and they refer to the emotional, intellectual, and physical aspects of sexuality. Healthy sexual boundaries involve mutual understanding and respect of limitations and desires between sexual partners. So between people who are in a committed relationship, there are healthy boundaries. Sexual boundaries can be violated with unwanted sexual touch, pressure to engage in sexual acts, leering, and sexual comments. And this can occur in the workplace, so be very mindful of that. Material boundaries refer to money and possessions. Healthy material boundaries involve setting limits on what you will share and with whom. For example, it may be appropriate to lend money to a family member, but probably not someone that you met this morning. Material boundaries are violated when someone steals or damages another person's possessions, or when they pressure them to give or lend them their possessions. And then we have time boundaries. Time boundaries refer to how a person uses their time. To have healthy time boundaries, a person must set aside enough time for each facet of their life, such as work, relationships, and hobbies. Time boundaries are violated when another person demands too much of another person's time. Then there are boundary components within these individual boundaries. So power, trust, respect, and professional intimacy. And let's break this down. Power. The power of professional caregivers, whether they be nurses, social workers, chaplains, radiologists, doesn't matter, comes from their professional position. The access to private information about the patient and the patient's need for care. Within the caregiver-patient relationship, a power imbalance exists between the caregiver and the patient. The patient's need for professional care makes them vulnerable. So I've had visits with people as a chaplain, and I've had people say to me, I've never shared this with anybody else. Well, there's a power dynamic to that. People feel comfortable talking to me as a chaplain, but that does create a power dynamic that I have to be very mindful of. And there's the trust issue. Trust is integral to a caregiver-patient relationship. Your patients must trust you that you will act in their best interest at all times. And trust can be fragile. It's important to keep promises. For example, I have a palliative patient that I see every week, and there have been a few times when I was going to be late, so I called him and said, hey, I'll be there in a half hour, I'll be there in 45 minutes, etc. And he has said to me, you don't need to worry about calling. If you can't come, just don't come. And while I am mindful of that, I call him anyways, because that one time that I can't come and I just don't show up could erode the trust. Even though he said you don't have to worry about it, I do it out of respect because I want to maintain that trust. Well, then we come to respect. Respect is the recognition of the inherent dignity, worth, and uniqueness of every individual, regardless of socioeconomic status, personal attributes, and nature of the health problem. Respect is basic in a caregiver-patient relationship, to knowing the patient as an individual with valued priorities, needs, and wants. I was very mindful of this once when I saw a patient and his wife, and they lived in a really nice house, smelled nice, it was clean, it was just a nice home. And then the next patient that I visited, not too far away, probably 10 minutes, and they had animals in the house. There was dog and cat hair everywhere. There was an odor in the house that I couldn't quite figure out what it came from, and it was a very contrasted experience. But I didn't treat the family or the patients any differently than I did the one that had the nicer house. So it's important that we offer respect and show respect to the patients that we provide care for. And then there's professional intimacy. Professional intimacy is inherent in the type of care and services that professional caregivers provide. This includes physical activities and psychological, spiritual, and social elements of care. Access to a patient's personal information contributes to this. Boundaries guide you in what you should say and do, as well as what you should not. So this kind of relates a little bit to power. And what I mean by that is I've had people that I've provided care to who, like I said before, have said to me, I haven't told anybody this before. And it's because of that dynamic between the person seeking care and my role as a chaplain. And so there is a sort of spiritual, emotional intimacy there when I meet with people and we talk about deeply personal things. But this also applies to when you're giving somebody a bath, or when you're cleaning somebody up, or somebody is extremely vulnerable because they have maybe they have a gunshot wound and they're in the emergency room, and you're doing all sorts of things to try to keep them alive. Professional intimacy really spans the gamut of healthcare providers, whether it's a doctor talking one-on-one to a patient in an observation room, whether it's an emergency room, or whether it's somebody's living room and you're talking about their past. Professional intimacy is something that we always have to be very mindful of. Now, here's two important concepts that I can't stress enough, and that is transference and countertransference. Transference refers to redirection of a patient's feelings from a significant person to a caregiver. Transference is often manifested as an attraction towards a caregiver, but can be seen in many other forms such as rage, hatred, mistrust, parentification, extreme dependence, or even placing the therapist in a godlike or guru status. And we can change therapist to nurse, social worker, chaplain, any caregiver out there. Transference can make a patient even more vulnerable. So let me give you an example. When I was in my chaplain residency down in West Virginia, we had to have a spiritual director. So we had 3 spiritual directors come and do a presentation to our clinical pastoral education group, and they came and talked about spiritual direction. There was a man and 2 women. After they gave their presentation, they left, and those of us, the students, were in the CPE room, and I started going off about the man who was presenting. Something about him I didn't like. I kept going on and on and on about how he rubbed me the wrong way. And then our CPE supervisor handed each of us an envelope. We opened the envelope, and it had the name of our spiritual director. And I got the guy that I had been ranting on for about 20 minutes. Well, later that day, we had what was called open group, where we were able to discuss kind of how we were feeling and what was going on in our life, etc. And I kept ranting again about this spiritual director that I got assigned to, how I felt cheated because he was now my spiritual director. And I wanted to know if anybody would trade, and my supervisor said, it's not optional, you can't trade. And then he said to me, who does he remind you of? And I immediately went blank, thought about it, and said, he reminds me of my dad. That's transference. Happens more often than we think. But then there's countertransference. Countertransference is defined as redirection of a caregiver's feelings towards a patient, or more generally, as a caregiver's emotional entanglement with the client. This emotional entanglement can cause boundary violations. So it's something to be very mindful of. So when you're providing care for somebody and you haven't met them before, but as soon as you see them, they kind of remind you of somebody. If that remembrance gets in the way of the care that you're providing, that's an example of countertransference. I recently visited with a patient, and the patient's daughter, who was probably about my same age, maybe a little bit younger, reminded me of someone that I used to date maybe 10 years ago before I got married and had a family. Now, if I let those feelings go unobserved and unprocessed, that could lead to problems. But I'm very mindful of the similarity in how they look, and I'm going to act professional because I'm aware of countertransference and how countertransference can cause problems. So here's a question. Is transference and countertransference, is it bad? And can transference and countertransference be avoided? Well, transference and countertransference, they're emotions, they're feelings. They're not good nor bad, they just are. It is what we do with these feelings that's important. So we don't have to try to avoid transference or countertransference. We just need to be mindful of it. So, for example, when I met that spiritual director, as soon as I observed his mannerisms and I thought, that reminds me of my dad, I should have acknowledged that to myself, but then reminded myself that he's not my dad. He's a different person. I've never met him before, and let's judge him based upon who he is and not perceived concepts that I have from my own father projected onto him. So transference and countertransference is neither good nor bad. It just is. It's emotions. It's how we feel. So we don't have to worry about whether it can be avoided or not, but it's what we do with it that is important. And that's why we talk about countertransference and transference while looking at boundaries, because it builds. So now let's look a little bit at boundary crossings and violations. What's a boundary crossing? Boundary crossings are brief excursions across professional lines of behavior that may be inadvertent, thoughtless, or even purposeful while attempting to meet a special need of a patient. So an easy, quick example, accepting a Coke or a Pepsi or a soft drink from a patient, if in their home, I consider that a boundary crossing. They're giving me a gift. I'm receiving that gift. But it's not something that's problematic in and of itself. So if they say, do you want something to drink? If I'm thirsty, I may say, sure, that would be great. Now, if they gave me a can of Coke or a cup of coffee, that's one thing. If they gave me a $40 bottle of champagne, that would be a boundary violation and a professional problem too, drinking on the job. So what are boundary violations? Boundary violations can result when there is confusion between the needs of the caregiver and those of the patient. Inappropriate relationships may start with something benign, then gradually progress until the caregiver has clearly violated a boundary. Boundary violations can cause distress for the patient, which he or she may not recognize or feel until harmful consequences occur. So now let's turn our attention to religion and spirituality. Now we have all this boundary and transference stuff understood. Let's talk about religion and spirituality. Joint Commission on the Accreditation of Healthcare Organizations issued the statement, patients have a fundamental right to considerate care that safeguards their personal dignity and respects their cultural, psychosocial, and spiritual values. Spiritual values is what, of course, we're going to focus on because patients have a right to that. And as caregivers, we need to be respectful of that. So we're going to look at religion, then we're going to look at spirituality. So at first, let's look at some definitions of religion to kind of give us an idea of what we're dealing with. Now keep in mind, some of these definitions are older, so they use gender-specific language. However, when men are listed, it also implies women as well. So the first comes from William James. Religion is the feelings, acts, and experiences of individual men in their solitude, so far as they apprehend themselves to stand in relation to whatever they may consider the divine. Then we have Catherine Albanese, who said, religion is a system of symbols, creed, code, cultus, by means of which people, a community, orient themselves in the world with reference to both ordinary and extraordinary powers, meanings, and values. Then we have Mark Taylor's definition. Religion is a complex adaptive network of myths, symbols, rituals, and concepts that simultaneously figure patterns of feeling, thinking, and acting and disrupt stable structures of meaning and purpose. When understood in that way, religion not only involves ideas and practices that are manifestly religious, but also includes a broad range of cultural phenomenon not ordinarily associated with religion. And here's a couple of other definitions, one by Sigmund Freud. Religion is comparable to childhood neuroses. And Friedrich Schleiermacher, the essence of religion consists in the feeling of absolute dependence. Some takeaways from these definitions of religion. There are just several definitions. There's lots of different opinions on what religion is. Some people view religion as negative. In my work in hospice, I teach orientation to new employees, and I always ask the question, show of hands, who has a negative opinion of religion? Raise your hand. And usually half the orientation class raises their hand. But when I ask about spirituality, everyone has a favorable opinion of spirituality. And the same is applicable to the people that we provide care for. Some will view religion as negative. Religion affects how people view the world. Religion shapes a person's worldview. Religion and culture are often intertwined. People can get very emotional when discussing religion. So now let's turn our attention to spirituality. Here's a definition of spirituality from the University of Minnesota's Center for Spirituality and Healing. I really liked it, so I included it here, and it says, spirituality is a broad concept with room for many perspectives. In general, it includes a sense of connection to something bigger than ourselves, and it typically involves a search for meaning in life. As such, it is a universal human experience, something that touches us all. People may describe a spiritual experience as sacred or transcendent, or simply a deep sense of aliveness and interconnectedness. Here's a graph that shows the relationship between religion and spirituality and the commonality in between. Linda Mercadante, in her book Belief Without Borders, said, a strong argument can be made that spirituality and religion essentially overlap. In fact, one study shows their closeness by calling spirituality privatized, experience-oriented religion. And she goes on to say that both spirituality and religion consist of 4 basic components. Belief in some kind of larger reality, some transcendent or sacred force, something greater than the individual, a desire to connect with this larger reality or greater force, the promotion of rituals and practices as an aid or witness to this connection, and the expectation of particular behaviors, whether called moral or not, that foster or demonstrate the desired connection. An important question. Since accommodating religious and spiritual beliefs is important within healthcare settings, how can we as healthcare providers accommodate these needs while maintaining professional boundaries? Well, I'm going to share with you 2 models for interaction. Both models are for interacting with patients and family that deal specifically with religion and spirituality. One is called H.O.P.E, developed by Brown University School of Medicine, and the other one, FICA, created by Dr. Christina Bukowski in 1996. So let's look at H.O.P.E first. Ways in which caregivers can interact with patients to accommodate spiritual needs while maintaining boundaries. H.O.P.E. The H, sources of hope, meaning comfort, strength, peace, love, and connection. The O, organized religion. P, personal spirituality and practices. And E, effects on medical care and end-of-life issues. Let's break it down. Questions that deal with sources of hope, meaning comfort, strength, peace, love, and connection. Questions such as, where do you find comfort or hope in this time of illness? When things are tough, what keeps you going? What sort of things bring you peace? Questions that deal with organized religion. Does organized religion have a place in your life or in your family's life? Do you have a church or parish that you attend? Some people may not be comfortable with the term organized religion because they may be kind of confused on what you mean by that. So the second one's probably better. Do you have a church or parish that you attend? Questions that deal with personal spirituality and practices. Are there spiritual practices or beliefs that are important to you personally? How do your beliefs shape who you are as a person? And questions that deal with the effects on medical care and end-of-life issues. Are there ways that your personal beliefs affect your healthcare choices or might provide guidance as we discuss decisions about your care near the end of your life? And then we have the FICA model, ways in which caregivers can interact with patients to accommodate spiritual needs while maintaining boundaries. F, faith. I, importance and an influence. C, community. A, address and care. Very similar to the H.O.P.E model. So let's break it down. Faith. Questions dealing with faith. Do you consider yourself spiritual or religious? Do you have spiritual beliefs that help you cope with stress? What gives your life meaning? Questions dealing with the importance and influence of one's religion, spirituality, and faith. What importance does your faith or belief have in your life? On a scale of 0, not important, to 5, very important, how would you rate the importance of faith and belief in your life? Have your beliefs influenced you in how you handle stress? What role do your beliefs play in your healthcare decision-making? Questions dealing with one's faith community. Are you a part of a spiritual or religious community? Is this of support to you, and how so? Questions about caring for a patient after insight into the patient's spiritual, religious life is known. How would you like your healthcare provider to use this information about your spirituality as they care for you? Now let's look at active listening. Active listening is a type of listening that focuses on the person you are providing care for and requires you to let go of your own personal views and focus on the world of the other person. So, for example, and I already mentioned that I've been involved with patients and they're talking about their politics, and sometimes it's very, very different from my own. And then after the visit, they just assume that I agree with them. I had one instance when I was in my chaplain residency down in West Virginia. This is when Barack Obama was president, and clearly the patient did not like him as president, and she went on and on and on for about an hour about politics. And then there was a slight window of opportunity that I had to kind of shift the discussion to talking about her cancer diagnosis. And once I had sort of earned the right after about an hour of her externalizing her emotions and talking about other things to now start talking about her diagnosis, which we did. And I learned that she was very fearful of that diagnosis and she was scared. And at the end of the visit, as I'm leaving, she says, "Oh, thank you, Pastor," because down there they refer to chaplains oftentimes as pastors. And then she added, "More people need to believe and think like us." Well, I didn't think anything like her, but she didn't know that because during the hour and a half that I was with her, I spent most of my time focusing on active listening. Now, from Philip Culbertson, from his book, Caring for God's People, Culbertson says, all verbal messages are codes, language equivalents of our feelings, but not the feelings themselves. So, for example, someone may say, "What time is it?" when they really mean, "I'm bored," or "I'm hungry." Someone may respond to the question, "How are you doing?" They may say, "I'm fine," but you can just tell that they're not fine. Language can be used to hide true feelings, and people will often externalize their feelings by talking about other things instead of what's really the issue, what's really on their mind. And through these practices of active listening, we can help decode what is being said. So be mindful that sometimes people will hide their feelings and externalize their emotions. For example, someone might go on and on and on about politics and how the world is a disaster instead of talking about their diagnosis, cancer, for example, because it is too painful to address the real issue of their illness. I had a situation with a family where apparently many, many years ago, there was a discretion within the relationship of this couple. And it had been forgiven and they moved on. Well, now the patient is dying of cancer and his wife does not want to talk about it. I mean, they'll talk about other things, but she does not want to talk about his pending death. She does not want to talk about the cancer. It's too difficult for her to have those kind of conversations. So what he's done is he's rehashed the past. He's brought up this infidelity that occurred many, many years ago in their relationship, and he's constantly bringing that up. And I suspect that it's because he can't talk about the real issue, which is, I'm going to be dying soon. In order to be on hospice, I have to have a diagnosis that the doctor says you got 6 months. So he knows that, and it's really getting to him, but she won't talk about those feelings. So he's bringing up other things from the past. And I don't think he realizes that he's doing this, but he's bringing other things up in the past because at least they're able to engage in something. But it's not the real issue. It's a way that he's externalized his feelings, I suspect, because he can't talk about the real issue. Active listening is so important. Active listening has the person providing care to use summaries of what they are hearing to help discover the emotion behind the words. So let's look at an example. A caregiver says, "Do you consider yourself spiritual or religious?" The patient responds, "I consider myself more spiritual than religious, but I do attend church every week. I was born and raised Baptist, and I've been in the choir for the past several years because I like to sing. My son was recently baptized in our church, and that makes me happy. I don't get all caught up in religious do's and don'ts, but I think knowing God is important." A good response to this, using active listening, would be, "Sounds like your church has been a great comfort to you. You mentioned that you like singing and that you're a part of the choir. Do you have other spiritual practices or beliefs that help you cope with stress?" That's a good response. A bad response, however, would be, "Well, I was raised Catholic and went to a Baptist church once. I briefly dated someone who was Baptist. The service was a lot different from what I was used to, but the music was good. Oh, do you have other beliefs that help you cope with stress?" That's an example of a bad response. Point of active listening is to listen, and then to listen some more. Personal information shared should be used to redirect the conversation back to the patient. So the patient might say, "I believe in God. What about you?" The caregiver responds, "I believe in God too. It seems that your faith is really important to you." Patient responds, "Yeah, it's very important." The caregiver can say, "Does your faith bring you a sense of peace?" Oftentimes I'll have patients say to me, "Well, what church do you go to?" And I'll usually respond, "I went to Methodist Theological School in Ohio. It's a seminary just north of Columbus." I don't really answer their question, but every time I've done that, in 7-8 years of being a chaplain, the response is, "Oh, okay." They're just trying to kind of vet me to see how I respond. I could go on and on about, though I believe in this, I believe in that, but that's not necessary. So I mentioned decoding. When you actually listen to someone, you have an opportunity to decode what you are hearing as you summarize. So here's the setting. Thanksgiving Day, patient has cancer and was admitted onto an oncology unit at the hospital. The patient says the following: I was cooking our Thanksgiving dinner and I just got so sick I asked my husband to take me to the ER. They decided to admit me again. I have been to the hospital several times over the past year. It is wearing me down. There was so much food. We always have our family over and I've always made Thanksgiving dinner. I've been doing it since our kids were born and they're all grown now. We have 2 new grandkids that were coming over. Had to cancel. Not sure what everyone is going to do now. I doubt my husband will finish dinner. All that food is likely to go to waste. So using active listening, you can decode what you hear and point out feelings as part of your summary. So you may say to them, "It's sad that all the food may go to waste and that you won't get to see your grandchildren and family. That must make you angry." If you point out an emotion and you get it wrong, do not worry. It is okay to get it wrong. The person you are talking to will correct you, and you can use the new information you receive from them to better help you provide care through active listening. So, for example, they may say, "Oh, I'm not angry. I'm just disappointed, almost heartbroken, and I'm scared. I wonder if I will make it to Christmas." So you have a lot of information there that you can use. They're scared, they're disappointed, they're fearful that they're not going to make it till Christmas, that they may die. So that's a lot of information that you can use in providing care to somebody. So some final thoughts on active listening. Remember to listen more and talk less. Remember the zone of helpfulness. You can share too much or you can be too distant. Don't interrogate them. Don't use the H.O.P.E and FICA model as a checklist. Don't make it sound like it's an interrogation. Have the conversation flow and be organic, but be mindful of those appropriate questions to ask to learn more about the patient, to learn more about what they're passionate about spiritually and religiously. Be mindful of boundaries. Look for nonverbal cues. Is there congruency between what they say and how they act? And remember, often emotions are hidden in language. So let's look at some things to consider, some things that will kind of look at all the different things that we've discussed. Here's something to consider. 1, Richard has cancer and has been recently admitted onto hospice care. Richard's wife, Susan, mentions that they were recently told that Richard has about 2 weeks before he will likely die from cancer. Susan goes on to say, "That's what the doctor says, but I want to know what the Lord says. So we're going to pray for a miracle." As she says these words, you can see Richard's facial expression changes. He seems downcast and looks down. What are some thoughts on this? Now, this is a difficult situation. A caregiver, whether that be a nurse, social worker, chaplain, or others, may feel powerless. What do you say? Do you tell him, you can pray for a miracle, but he's probably still going to die? No, you don't say that, but you may think it. Susan seems like she does not want to accept the prognosis and is in denial, using her religion to obfuscate her true feelings. Richard's change in facial expression seems to indicate that he does not share his wife's need to hide feelings. He may need to talk about his own feelings. Something to consider too. Amanda is a hospice aide and has 10 patients that she sees regularly. Amanda spends about an hour with each patient with each visit. She gets a new patient named Sam added to her caseload and discovers that Sam is of the Baha'i faith, the same faith as Amanda. After a few weeks, it is noticed that Amanda is spending an hour and a half with each visit to Sam. And when asked about this, she states, well, he really needs some extra care. So, some thoughts on something to consider too? Well, Sam may need extra care. That is a possibility, but Amanda should be able to explain why he needs extra care. But he may not need extra care. Instead, it could be a case of countertransference with Amanda feeling that she needs to give extra care because of their shared religious beliefs and her feelings getting tangled up with the patient. So then we have something to consider 3. Agnes lives in a nursing home and has Parkinson's and has limited speech and likely some dementia. Agnes lives in an assisted living facility and her family hired a caregiver, Sally, to stop in and assist the staff at the facility in caring for Agnes. Agnes is sitting in her wheelchair next to Sally, and you hear Sally say to an aide at the facility, "I've been praying for Agnes for years that she accepts the Lord. I'm afraid where she's going to go, and when she dies because she hasn't been saved." You know from the patient's face sheet that her faith background is Christian Science. Some thoughts on this, something to consider 3. It is inappropriate to say this about a patient that you are providing care for. You can think whatever you want, but be careful what you say. Remember the boundary components of power, trust, respect, and professional intimacy. All 4 of the components could figure into this situation as Sally has power over Agnes, and there is a trust relationship between them, and clearly Sally does not respect the religious choices that Agnes has made. Sally provides close care to Agnes, who is very vulnerable. Remember intellectual and emotional boundaries. Something to consider 4. Ann has been providing care to Jack for a year or so, and Jack's faith is important to him. Jack often talks about his faith to Ann, who is a good listener. Jack takes an old book of devotions from his bookshelf and hands it to Ann, indicating that he wants her to have the book, knowing he will be dying soon. Ann indicates she can't accept gifts and doesn't take the book. During her next visit, Jack hands her the book again and says, "I really want you to have this." So let's look at this. It's a boundary situation. A boundary crossing is not necessarily unethical, but has the potential to be unethical. The book in question is an old book that would likely go for next to nothing at a used bookstore. A boundary crossing, like accepting a Coke or a cup of coffee at a patient's home. Now, if the old book was a first edition Stephen King novel from the 80s, for example, that could potentially sell for hundreds of dollars, that would be a boundary violation. Something to consider 5. You go to visit a new patient named Bruce, who has a diagnosis of liver cancer and not much time left to live. Upon entering the home, several of Bruce's adult children mention that they forgive their father for the things he has done, although one of the patient's sons seems reluctant. Upon meeting Bruce, he tells you that he was an engineer who always kept his family at a distance, and he also mentions that he used to cheat on his wife, who is now deceased, and that he was rarely there for his kids. The patient says, "I don't think God will ever forgive me, and I'm sure that I'm going to hell." Some thoughts on something to consider 5. Remember coded language. When people say God will never forgive me, it is usually coded language indicating that they cannot forgive themselves. Bruce seems to be holding a lot of regrets and grief. The patient's children seem to have their own struggles with their father's past behavior. Something to consider 6. Mary is a registered nurse who has been caring for Gladys for about a year on hospice care. Gladys lived by herself but can no longer live alone, so she moves in with her daughter. Gladys is a Jehovah's Witness, and Mary too is a Jehovah's Witness. Mary has said, "Gladys has special needs, and she needs me as her nurse. I understand her." Mary has requested to continue seeing Gladys after she moves in with her daughter, even though it is a different area and team within her hospice company. Some things to reflect on. This could be a case of countertransference and transference. Gladys could be telling Mary, "I need you as my nurse. You're the only one who gets me." Mary may feel that due to their common religious background that Mary is the only nurse who can give good care to Gladys. Is it always a bad thing to honor requests such as this one? Well, of course not. However, while it is important to maintain trust, it is also important for caregivers to recognize the effects of countertransference. So if the new territory that the patient's going to is nearby, it may be appropriate for the nurse to continue care. The nurse could also continue to make some visits with the new nurse to sort of help with that transition. But the most important takeaway from this is to be aware of the effects of transference and countertransference. You can still accommodate a request, but knowing the effects of countertransference, knowing that you're not the only nurse that can provide good care, it is important. That's the important takeaway from this one. Then we have something to consider 7. Frank is a Serbian Orthodox Christian and resides at a skilled nursing facility. Frank is actively dying and is no longer alert and oriented. Deborah, an STNA, is assigned to sit with Frank so he does not die alone. There is no family present, and Deborah feels sad for Frank. Deborah uses her smartphone to pull up gospel music to play to Frank while he lays in bed unresponsive. And some reflections on this. Deborah felt that gospel music would be comforting to Frank as he died. There is no indication that Frank values or appreciates gospel music. An intellectual boundary violation in that Deborah is not showing respect for Frank's own spiritual views by imposing her own. Even though her intention is to do good for Frank, she unknowingly may be causing him discomfort. I've seen this several times, where STNAs sitting bedside will play gospel music thinking that they're providing comfort, but they may not be. What if the patient's Jewish and the STNA is not aware? What if they're an atheist? What if they're in a different tradition of Christianity that may not value gospel music? It would be like playing Gregorian chant to a patient who, let's say, is Pentecostal. Now, they may like Gregorian chant. They may value it like classical music, and it may be comforting, or it may be off-putting. So it's very important that we be mindful and be respectful. Even if our intentions are to do good, we may actually be causing harm, but not be aware of it. And thus concludes the presentation. Thank you for listening.